So watch this PowerPoint along with your major burn case study notes. So it starts out, Mr. Brian Burns is a 20-year-old male. He was admitted at 11 a.m. after his clothing ignited at the gas station where he is employed part-time at approximately 10:45 a.m. His trouser legs, on which a moderate amount of gasoline had been spilled, ignited from sparks of a torch he used in the auto repair area of the garage. Mr. Burns sustained a partial and full thickness burns. Brian describes his health as excellent before the accident. He reports he is current on all immunizations. The distribution of the burn is depicted in the following anterior-posterior views that is shown later in this PowerPoint. Upon his physical assessment, he's laying in bed in obvious physical discomfort with frequent facial grimacing. Right hand, forearm, and both legs are wrapped in bulky dressings. Breathing without difficulty. He's 180 pounds and he's 5'8". His temperature is 97.4 oral, heart rate 110, and it's regular. He has respiration rate of 24, and it's regular, and his blood pressure is 100/60 in his left arm. And his skin is pale moist, but edematous, with areas of partial and full thickness burns. His nails on the left hand and both feet are intact. The capillary refill is 3 seconds on the left hand and 4 seconds on the right and left feet. The right hand is not examined due to the bulky dressing. His mucous membranes are pale and dry. There is some edema on the neck, but no burn lesions. His chest wall is without injury. There are slight crackles at the bases noted bilaterally. There is no wheezes noted. He has symmetrical chest expansion. Cardiovascular, he has no murmurs, rubs, or extra sounds. His PMI is palpable at the fifth intercostal space. His apical pulse is regular at 108 per minute. A central line is in place in his right subclavian vein. He has peripheral pulses strong and equal bilaterally in upper extremities. The pulse is strong in the left leg, but not assessed in the right due to the dressing. His abdomen is symmetrical with slight distension. Bowel sounds are absent in 4 quadrants. No masses, pain, or tenderness. His musculoskeletal system has full range of motion in all joints that have not been affected by the burn injury. And he is strong despite his injury. Neurologically, he's alert and oriented ×3. He has coordinated movements. Sensation is intact on unburned surfaces. Genitalia, he is a circumcised adult male. No burns noted. He has an indwelling Foley catheter, and urine is dark amber, and his scrotum is edematous. Diagnostic tests, he has hemoglobin of 18.3, hematocrit of 48.5, his sodium is 145, his potassium is 3.6, his CO2 is 24, BUN is 13.4, creatinine is 1.5, carboxyhemoglobin is 1.5, his ABGs, the pH is 7.39, PO2 is 94, PCO2 is 40, and his SaO2 is 97%. His urine-specific gravity is 1.04. The pH is 5.5. There is trace blood in the urine. There is protein, 8 milligrams per deciliter. Trace amount of glucose and ketones. Chest x-ray is normal with no infiltrates, and his EKG shows sinus tachycardia. Some common orders will be NPO, so that is so we can assess the GI motility. They will be giving morphine sulfate or other intravenous opioids because they cannot take PO due to decreased absorption from muscles and stomach due to the third spacing. They will be having hourly urine output, which is the most sensitive indicator of cardiac output. They should have 0.5 to 1 ml per kilogram per hour of urine output. EKG if they have electrical burns, because it does affect the conduction system. They also might have MIs due to the stress and electrolyte changes, including potassium, so they should be on cardiac monitoring. The head of bed will be 30 degrees to promote ventilation. Range of motion will be performed, and usually the position of comfort is the position of a contracture. So patients can develop contractures very easily due to the non-pliable skin at joints. So PT and OT will work on making them splints. PT will encourage ambulation to strengthen muscles. Superficial partial thickness is a burn of the entire epidermis and varying levels of dermis. The appearance will be red, it might be dry, it will blanch, so that means it'll make a white mark when you press it. It can have blisters and it is painful. And an example would be a sunburn. A deep partial thickness, it goes deeper into the dermis. Appearance may have blisters, it'll be red, and it's important to include it will be wee and have edema. The hair follicle will be intact and it is painful. Full thickness is deep subcutaneous. It may affect muscle and bone. It's going to appear hard, dry, with eschar, and have edema, but it will not have pain because the nerve endings are in the dermis and has gone all the way through. So the pathophysiology of a burn, there's tissue damage, then there is histamine release and protein leak. This will increase the capillary permeability, decrease cardiac output, and decrease tissue perfusion. There is possible pulmonary damage if the patient is in an enclosed area, has facial or neck burns. They may have singed nasal hair, hoarseness, stridor, sooty sputum, or respiratory distress. And this is just a view of a normal airway via bronchoscopy, and then on the other side is one that has been in a fire. So you note that they have a heat injury, plus they have soot. So in the upper airway, they can have direct heat and edema injuries. That can lead to upper airway obstruction. The treatment is intubation. They can also have inhalation injuries. That would be irritants from gases. This causes atelectasis, and they also might have carbon monoxide poisoning, which is done monitored through carboxyhemoglobin levels. Treatment is intubation and 100% oxygen. They also might have restrictive defects. This would be eschar and edema to the neck and chest. This in turn decreases the tidal volume and can cause respiratory distress. And the treatment is an escharotomy. This is where they cut up through the eschar tissue so that the chest can expand again. Cardiovascular alterations in treatment. So these typically last 24 to 36 hours after the initial injury. Because of increased capillary refill and fluid loss, we have decreased cardiac output and hypovolemic shock. So we are treating that with fluid resuscitation. They may also have anemia, and this would be treated with blood products. Fluid and electrolyte alterations in treatment. Alterations would include edema, which could be either local or systemic. So we are going to elevate burned limbs to the level of the heart. Compartment syndrome, this is when there has been eschar restricting the ability to swell of the limb, and this is treated with a fasciotomy and an escharotomy. We need to evaluate for excess fluid resuscitation. So we're going to be listening to the chest to hear if we have any wet breath sounds or crackles. Our patient might experience evaporation losses. If large percentages of their surface area are burned, then they will have evaporation losses. Our skin normally keeps all of our body fluids inside, and this would give it a route to escape. Our patient will have hyponatremia or hypokalemia, so we're going to monitor electrolytes. We're going to cover their wounds, we're going to monitor their urine output, and again, we're going to do that fluid resuscitation using the Parkland formula. Other body systems that are affected would be our renal system. And there is decreased perfusion to the kidney due to hypovolemia. We're going to monitor urine output hourly, and we should have 0.5 to 1 ml per kilogram per hour. This also determines our cardiac output. Immunologically, we're going to have increased risk of infection. They have impaired tissue integrity. They might be in a hypermetabolic state, and this increases blood glucose, so this can actually fuel our infections. So they may be on antibiotics, they may be on an insulin drip. Dressings are always sterile in the burn unit, and we wear increased PPE. Thermoregulatory, so they're unable to regulate their temperature due to loss of skin. That's one of our skin's jobs. So they are dependent on the environment to control their temperature. So rooms are kept very warm. And then the GI system, we have decreased absorption in the GI tract due to the inflammatory response and due to third spacing. So we need to feed early past the pylorus. So the rules of nines, we do need to memorize this figure. Notice that a whole arm is 9, but a whole leg is 18. And the torso is split in half. So we have our upper chest and abdomen. We have an upper back and lower back. So that might be a good way to divide it. Our head is totally 9. So just memorize that figure. So our patient had a burn on the right arm, right leg, and left leg. But the right arm was the lower half, so that is 4.5. The right leg was total, so that is 18. And the left leg was total anterior and half of the posterior, so that was 9. So we have 4.5 plus 18 plus 9 plus 4.5, and that's 36. We're going to use the Parkland formula. When resuscitation, we always use lactated ringers, or LR, and the formula we will be using for our class is 4 milliliters times the amount of kilograms the patient is, times the amount of total body surface area burned. We're going to divide that number into half, and the first half is how much they receive in 8 hours. To determine our rate for our IV pump, we're going to take the half divided by 8, and that's our mLs per hour for the first 8 hours. And then we'll take the second half, we'll divide it by 16, and we'll get our mLs per hour for the next 16 hours. So our patient, we're going to do 4 mLs. He is 81.8 kilograms times 36. And then we get 11,779.2 mLs in the first 24 hours. That's how much we're going to give him, and that is almost 12 liters of 12-liter bags of fluid. And then like I said, we divide it in half. The first half we divide by 8 hours, and that's our mLs per hour for the first 8 hours. The second half we divide by 16, and we get how many mLs per hour we're going to program our pump for the next 16 hours. So we're going to have to monitor our patient for fluid volume deficit versus fluid volume excess. Our patient who is in deficit is going to have tachycardia. Blood pressure is going to be low. They might have a high hemoglobin and hematocrit and a high urine-specific gravity. Our patient with the fluid volume excess, basically because they have so much swelling, it's difficult to tell from that, but they might have hypertension and they will have crackles in their lungs. Nutritionally, they're going to have a higher demand to heal all of those wounds. So we're going to do a high-calorie, high-protein foods. We're going to avoid empty calories. They're going to be on protein supplements like Magic Shake and DuoCal. We need to make sure we know their food preferences when we plan out their meals. If they are unable to eat orally all of their calorie needs, then they may have feeding tubes, and it will be placed past the pylorus. We're also going to be monitoring their serum albumin and protein levels. Those are our #1 determinants of nutrition. Their calorie needs may be 3 to 4 times higher. Our patients who eat by mouth will always be on a calorie count. And we do not worry about diabetic diets at this time, so they may have high blood sugars due partly to the inflammatory process, but also because they are eating high calorie, high sugar. So we will be putting them on insulin drips. Compartment syndrome can happen when there is a burn that goes all the way around a limb. We need to look for the 6 P's. They may become pulseless. They may have pallor, and that's like lighter color. Paresthesia, that's altered sensation. Pain, paresthesis, it might become weaker. Or poikilothermia, that means it's cold. The treatment is an escharotomy, and that's where they cut up the side of the limb so that it can, it's not restricted anymore. An autograft is from a patient's own body. They basically put the skin through a mesher, and they are able to use a smaller piece of skin to cover more area. This is then sutured or stapled in and covered. We need to protect these so that they can actually start to grow and cover the skin. Culture skin, there is a biopsy sent, and this is grown in a lab, but it's extremely fragile. And in the picture, they show it being stapled. Heterografts or xenografts are pig skin. These are very common, but they have to be changed every day. Homografts or allografts are from a cadaver. Most important points when taking care of grafts, we need to immobilize the grafted areas with occlusive dressing so that they don't come off or they don't become disrupted. We need to be very careful when turning them to avoid shearing injuries, and we need to elevate the grafted extremities to decrease edema. Emotional coping is something important to think about when caring for our burn patients. They're going to have disfiguring, crippling pain, and a big interruption into their normal life that can last months and years. So we can expect depression, regression, withdrawal, and manipulative behavior. They may even choose risky behaviors like alcohol and drug abuse to deal with the pain and trauma. So it's important to set behavior expectations with your patients, build trust through open and direct communication, use positive reinforcement for appropriate behavior, and demonstrate acceptance. And I included some videos about working in a burn unit and a burn survivor video.